Welcome, everyone, to another episode of MASH Masters. I'm Dr. Naim Alkhouri, the Chief Academic Officer at Summit Clinical Research. We have an exciting episode for you guys about liver-directed MASH therapies. This is sponsored by Madrigal Pharmaceuticals. And we are doing this episode with the one and only Dr. Mazen Noureddin, who's a dear friend. He is a professor of medicine at Houston Methodist Hospital. He is also the Chief Scientific Officer and co-chair of the board at Summit and Pinnacle Clinical Research. Welcome, Dr. Noureddin. Thank you for joining us.
Thank you, Naim, for having me.
My pleasure. So we live in exciting times. Last year, we had the first FDA approval for a MASH drug, and we expect to have another one this year. And that's why we have you here today. So walk us through the data about resmetirom that led to the first FDA approval.
Yes, sir. And as you said, it's really exciting times, and we have a drug approved. Next one, hopefully coming in. The pipeline is so rich. But let's see how this got started last year, or how we landed with the drug approved. That was the phase 3 MAESTRO-NASH trial that you and I were part of. And that was a placebo versus 80 milligram versus 100 milligram in MASH patients with at risk of significant advanced fibrosis, F2 and F3 mainly. There were some F1s in that trial. And that trial, as you know, like to get Subpart H approval, you do a biopsy study with baseline biopsy, follow-up biopsy, and the duration here was 52 weeks, which is a year. And of note, the trial is ongoing, so we can show that we prevent complications of liver-related disease outcomes, decompensations. So we will see the results in the future, including preventing progression of cirrhosis. Again, 1-year study with biopsy, paired biopsy, and the outcomes are the traditional ones, either MASH resolution without worsening of fibrosis, or fibrosis improvement without worsening of MASH. So the point is, if you hit one of them, you get Subpart H FDA approval, and this is what happened in this study. Indeed, we hit both endpoints. Let's take a look at the next slide. So this is what I show here on the left. On the left, I show the first primary endpoint, which was MASH resolution without worsening of fibrosis. We hit that, and that was statistically significant. On the middle, I show you the one-stage fibrosis improvement without worsening of MASH, and we hit that primary endpoint. So we hit both primary endpoints, which was great. On the right, I show you a bonus that lipid panel improved LDL here with THR beta receptors, showing additional benefits for this drug beyond the liver. Next slide. So we also showed that the things that all hepatologists, gastroenterologists, and primary care like, which is improvement in liver enzymes. And here you see nice drop and quick with resmetirom in this trial, in addition to histological benefits. And that continued throughout the 48 weeks when we examined it last time in this study. Next.
Very exciting data, and this is encouraging to see. One thing is, the study was based on histology, and you needed the biopsy at the beginning, a biopsy after 52 weeks to show MASH resolution and fibrosis improvement. But in the real world, we try to avoid biopsies. So how do you select patients for treatment in your practice, and do you have any guidance for our colleagues?
Yeah, Naim, if you recall, we were preparing for the outcome, which did not happen. The FDA gave the sponsor a drug approval, and we were pleasantly surprised that there were no comments on the biopsy, which is reasonable, right? Because in real life, what we do is non-invasive testing and combination of them, and then we look at how they improve or worsen over time, and we make decisions on anything related to MASH. And in this situation, or in this approval, a group of us got together, as I mentioned, like you were one of the working group all together that we did the trial, and we decided to put this document out there to fill the need to understand how we prescribe the drug. There was also a follow-up effort by the AASLD guidance, which is very similar, and I'll start showing you both of them. But in this effort that came out shortly after the drug approval, what we said, we look at MAESTRO MASH patients, and we rule out other causes of liver disease, and then we have to identify at risk of MASH patients. And those are the significant advanced fibrosis or moderate advanced fibrosis, whatever you want to call it, but basically what translate back in the days F2 and F3s. And let me start with the red box here. Those are the people that you cannot and you should not treat as of today. And basically those are the cirrhotics. And this is a very important point until we have further data, especially in decompensated cirrhotics. So we used many guidance as well as the baseline data at the MAESTRO-NASH trial. And those with VCTE, or what a lot of us know as FibroScan, and there are other machines as well, of 20 kPa and above are considered cirrhotics, and they should not be treated. The equivalent of that on MRE is a 5 kilopascal. So you remember 5 and 20 on the ELF 11.3. Then on the left, you have the range of treatment. And the range of treatment, there's the orange to be cautious, and the orange not to treat the cirrhotics. And basically here in our document, VCTE between 10 and all the way to almost 20 are treatable population. But once you passed the 15, so 10 to 15 is more straightforward. Once you pass the 15, you start looking for other signs of cirrhosis on imaging. You look at the platelet, they should be more than 140. So it's just like the clinical picture we're used to not treat cirrhotics. And you should do it anyways, anywhere between 10 and all the way to 20. There are equivalents on MR elastography between 3.3 all the way to 4.9, and the ELF score 9.2 all the way to 11.3. And with the ELF, we caution people maybe to use additional imaging in this study. And there are the conventional or the scores that identify at-risk MASH that are mentioned in the AASLD document. And let me show you, Naim, on the next slide, maybe the AASLD document, which is very similar to the document, what we put with slight differences. Maybe the AASLD guidelines start a bit earlier on the 8th. We wanted to be a little bit more specific in our document, but we'll leave it to people discretion on what to use on this population.
I love this, Dr. Noureddin, and this is like a traffic light. So you have the green zone, treat with confidence. You have the yellow zone, treat with caution, and you have the red zone, do not treat. This is lovely. I can tell you in our practice, we've treated about 500 patients with resmetirom after the clinical trial in the real world, and we qualified about 95% based on transient elastography. We have about 10% on ELF, and another 10% that had a historic biopsy. So this is great. We know how to select the patients, but then how are you going to follow the response and decide who's responding and who's not without doing biopsies? Let's go to
let me show you the next slide, Naim, for that. So yes, and this is both the AASLD and the expert panel consensus, but it's straightforward, Naim. Let me just summarize it to you. At 3 months, a lot of people want to bring the patient back. Yeah, bring them back, check the liver enzymes, see how things are going, if there's any red flags or anything like this. Especially the red flags usually when you have another etiology that people are missed it, such as alcohol-related liver disease or autoimmune. So you have to rule them out from the get-go. But at 3 months also, if you see something funky, just pay attention to that. What I do, I bring them back in 6 months, and this is when I start looking at early responders, and I look at VCTE as well as liver enzymes, or if I use MRI PDFF, I look at that. And it could be a little bit too early for MRI in particular. The decision where you need to decide what to do is at 1 year, and this is where the trial showed efficacy. So what we look at multiple things. I look at the combination of liver enzymes drop by 20%, and VCTE dropped by 30%. The AASLD guidelines say 25% for VCTE. We say 30%, so it's kind of the same range. So I look at the combination between this ALT and VCTE, and I see them dropping and continue. If I see them flat, I continue as well, because this is a long evolving process. And if they're worsening, you may stop, but you also really want to look at other parameters or other etiologies. Again, alcohol is a big elephant in the room. So this is how I look at it, Naim.
That's excellent and very simple. So we expect another FDA approval hopefully this year. So you want to share with us the data with the semaglutide?
Yeah, so there was another phase 3 study that finished after, and I want to point a slight difference is with the semaglutide, the trial was done over 72 weeks, the biopsy trial, instead of the 52 weeks, so it's a bit longer. And here we had a 3 arms. We had, I'm sorry, the semaglutide 2.4 milligram compared to the placebo. There was a titration on the dose, so that is common with all GLP-1s. And with the biopsy, we had your conventional MASH and F2 and F3 patients in this trial, and we looked at the biopsy at week 72. And again, the trial is still ongoing until we get to outcomes. So let's take a look at the next slide, what happened here with the paired biopsy over 72 weeks. So they did hit NASH resolution without worsening of fibrosis, and I show you that on the left. And on the right, they did hit fibrosis improvement, which is also statistically significant over 72 weeks. So duration is different, deltas are a bit different, something to keep an eye on. But this is usually comparison is done in head-to-head trial. Another benefit for our patients with this GLP-1 that is injectable. Next slide.
What the data on semaglutide is very promising. Let me just ask you one question before we move on to the next agent. Are you able to use resmetirom and semaglutide in the same patient? Because we know semaglutide has the obesity indication, the type 2 diabetes indication. Has that been something that you've done in your practice?
Yeah, so when we had the liver-directed therapy, the only liver-directed therapy, which was resmetirom, with my patients with MASH and F2 and higher, I started resmetirom in these patients, and I reassessed the other comorbidities such as obesity and type 2 diabetes within 3 or 6 months. The reason why I don't like to start 2 medications at the same time, that's personal opinion, and especially if there are side effects, which is you see in different drugs. I like to wait for one and then add the other. So usually I start with resmetirom and I follow with semaglutide. I expect that there will be guidance in the future on how to use them, one versus the other or combine, but we need more studies as well.
And on the flip side, if someone has been on a stable dose, semaglutide or even tirzepatide for the diabetes indication, for example, you can add resmetirom on top of it if they continue to have F2 and F3 fibrosis. So it should give some reassurance to providers that, it's okay to use both of them in the same patient. And that was the case in about 15% of patients in MAESTRO-NASH. Well, moving on, I guess we have, as you said, a deep pipeline and very exciting agents. So what's coming up in the next few years?
Yeah, I mean, now we're going to go Speedy Gonzalez, and I'm going to throw all these medications out there. But two important ones, or few important ones, sticking to the GLP-1 since we just parked there. Tirzepatide is not a GLP-1 only, it's a GLP-1 GIP. And this phase 2 trial, they hit the histological improvement, NASH resolution. They also saw improvement in fibrosis, which gives a hope. We need phase 3 study for this drug. Which I hope to see in the future. So that's one out there. If you give me the next slide, I want to talk about another one, which is GLP-1 glucagon. The first one is GLP-1 GIP tirzepatide. This is GLP-1 glucagon. And in these trials that we were part of also hit NASH resolution as well as fibrosis improvement, in addition to improvement in liver enzymes and weight loss. A third one, which we don't have a slide on, but they just had an announcement. The uniqueness of that one's called pemvidutide GLP-1 glucagon. They did the biopsy earlier than other GLP-1s. So the tirzepatide as well as surfudidide, you see the biopsy at 1 year. Pemvidutide did the biopsy at 6 months, and they did hit NASH resolution. They were close to fibrosis improvement, statistical significant. They hit that on AI, and they also saw a good weight loss at 6 months. So that makes it the first drug that shows histological response at 6 months among the GLP-1 drugs in addition to weight loss. And finally, I'm going to throw the last 2 medications out there that are very promising, which is FGF21, efruxifermin, as well as efimosfermin. There's also pegozafermin. Efruxifermin, there's now data showing very high NASH resolution fibrosis improvement, and they reverse fibrosis in cirrhotic patients. Efimosfermin also hit the primary endpoints at 6 months. So the future is really bright, Naim. And as you can tell, there's so many in the pipeline that we're excited about.
Yes, very exciting for our patients, and hopefully in a few years we'll be able to treat MASH cirrhosis also, which would be a big win. For completeness sake, also we have lanifibranor in a phase 3, and hopefully we'll have the results of that one in a year or so. So again, many new developments, and I couldn't be more excited. Thank you so much, Dr. Noureddin. That was an excellent overview of already FDA-approved medications and the pipeline. If you guys are interested in learning more about MASH clinical advances, please visit the Medscape page, Advances in MASH, and we hope that you join us in the next episode. Thank you so much for your attention.
Thank you.